Good morning, and thank you for coming to the acute stroke session. We are delighted to have you here. I'm Latha Ganti. I'm going to be the moderator for the session, and our session this morning is called New Frontiers, Management of Acute Ischemic Stroke in the Extended Time Window. The exciting part about doing this session at SAEM is it seems like every May is when all the new latest and greatest stuff comes out. So when we're telling you that we're telling you the latest stuff, it really is the latest stuff. One of the studies we're talking about was published just 72 hours ago. Brief outline of the talk. Dr. Goldstein here is going to be talking about the DAWN and Diffuse trials. Dr. Wira will be talking about advanced neuroimaging and Mr. Witness. And I'll be speaking about Wake Up, Extend IA, and NORTEST. We are delighted to present this on behalf of the Neuro Interest Group at SAEM, and we have several of our panel members here. Dr. Sozener, Dr. Lewandowski, Bill Meurer, and Dr. Miller. Some of them are here also as well with us. Okay, Dr. Goldstein.
Thanks so much. All right, so let's see here. Our panelists can't see the slides, so I was just trying to think of if there's an easy way to do it. All right. What was that?
Panelists can come down and sit in the front row so they can see your slides.
Yeah, you want to just do that maybe? Or and then come back up to the panel? All right, oh, there we go. Yeah, if you could put them up there. All right, so welcome everybody. So I'm going to talk about the oldest data, which is months ago. So it's really old, and I'll be highlighting a couple trials, DAWN and Diffuse, which have really changed the way we think about people who have stroke of either unknown time onset or longer time windows than we're used to dealing with. So DAWN was a randomized trial of thrombectomy between 6 and 24 hours after stroke with a mismatch between deficit and infarct. The key thing that I want you to look at is thrombectomy 6 to 24 hours after stroke. So our traditional time windows for intravenous or endovascular therapy, we had discussions about out to 3 hours, then out to 4.5 hours, then out to 6 hours for thrombectomy. So what this group looked at was it randomized 206 patients in 26 centers to thrombectomy or medical management. And the magic piece here, and this is really what's, I think, a common theme you'll see between our talks, is how do we take somebody who maybe doesn't know what time it is, or we're using their last known well time, which isn't really the onset time, it's our best surrogate of it, and how do we use clever imaging to find a better marker of how far in you are to your stroke, or how big is the opportunity to benefit. So inclusion criteria, use of the Trevo stent retriever. This trial was funded by Stryker, the maker of that stent retriever. Last known well time was between 6 and 24 hours ago. There's occlusion of the internal carotid artery or middle cerebral artery on CT angiography or MR angiography. There's a mismatch between clinical deficit and infarct. In other words, you take the size of how big is the patient's clinical deficit, how big is the size of dead tissue that you see on MRI or CT perfusion, and if the patient's clinical syndrome is much larger than that deficit would account for, then you presume that there's a large territory of ischemic but not yet infarcted tissue. And then randomization, interestingly, was stratified by age, NIH stroke scale score, and infarct size. The results, and I want to highlight here, when you look at the kinds of people who were enrolled in this stroke, 63% and 47% were onset was on awakening. In other words, they woke up and found with their symptoms. Another 27 or 38% were unwitnessed stroke, were found and nobody saw or knew when they were last seen well, and a small amount were witnessed stroke. So the majority of these patients were sort of wake-up strokes or unwitnessed strokes. The interval between last known well time and randomization was 13 hours, so you can see this is a dramatically longer time window than our typical stroke interventions have been. And time from observation of symptoms to randomization was 4.8 versus 5.6 hours. So even if you take found with symptoms time, this is still a relatively longer time window. And so here were the results. If we take the use of mismatch between the imaging findings in your clinical deficit and this extended time window, the proportion of patients with So a score of 0 on modified Rankin scale score is no symptoms. A 1 is mild symptoms that aren't affecting you. Out here is death. And you look at the thrombectomy group, more people have no symptoms than the control group. A lot more people have mild symptoms, and a lot fewer people have death. You can see that this whole range is shifted towards people with better outcomes, and the control group towards worse outcomes. So then a parallel study that was somewhat similar came out, Diffuse 3, thrombectomy between 6 and 16 hours with selection by perfusion imaging. Again, 182 patients in 38 centers randomized to thrombectomy versus medical management. Last known well between 6 and 16 hours. And here, this was, instead of using clinical deficit to a mismatch between your clinical syndrome and infarct on imaging, your infarct had to be less than 70 cc's, and the ratio of ischemia to infarct had to be 1.8 or more. In other words, you had to have a lot more ischemia compared to infarct. With the idea being that if it's all infarct and no ischemia, that person has no opportunity to benefit. If it's all ischemia but no infarct, that person has a huge opportunity to benefit. In the penumbra, the size of that difference, that ischemic but not yet infarcted tissue, has to be 15 cc's or more. Again, the occlusion has to be in a large vessel, the internal carotid or middle cerebral artery, on CTA or MRI. Here, again, we see how many of these folks had witnessed onset, 34, 39%. Symptoms present on awakening, 53 and 47%. Again, a lot of these folks are basically wake-up strokes. And symptoms began while awake, 13, 14%. Median time from stroke onset to imaging, 9 hours, 10 hours. So again, this is a much longer time window than prior strokes. And then time from imaging to femoral puncture was an hour. Our mission in the future is going to be to take that down. That's even in the context of this trial where they're really trying to push people to faster times to treatment. And again, we look at this sliding scale. The proportion of people with modified Rankin score of 0 was maybe similar between the two groups, but one, mild symptoms, vastly more in the endovascular therapy group. Score of 2, which is still more symptoms, but still many consider a good outcome, vastly more here. And the medical therapy group had a lot more people dead and in poor outcome groups than the endovascular therapy group. So a clinically significant, a statistically significant shift towards better outcomes in the endovascular group. So the conclusion really is that when we use when did somebody last see you well is a very crude marker of how far along you are in your stroke. And what's probably true is different people are converting from ischemic to infarcted tissue at different rates. So even the clock on the wall is still a much more imperfect measure of your opportunity to benefit than our imaging can provide. So we can use imaging to see who has ischemic but not yet infarcted tissue even up to 24 hours. And if you're going to do it, you need a large vessel occlusion and a small core infarct. For people with good function at baseline and big strokes, endovascular therapy is providing statistically and clinically significant benefit for people with good imaging characteristics. And I'll stop there. And I'll go ahead and move to Dr. Wira, who's going to give our next talk.
Thank you. Pleasure to be here. And as I think most people obviously in the room are aware, we have had great evolution in stroke care over the course of the past decade. And being an emergency medicine provider who also takes call for Yale, this is essentially my stroke fellowship over the course of the past 10 years, reading all these articles. But, more specifically, I mean, over the course of the past couple of years, there's been just such dramatic change in the treatment opportunities that we have for patients. And some of the changes that we have seen have been, as Dr. Goldstein mentioned, in the interarterial trials with the Dawn and Diffuse. As I'll talk about, we also have some advances as well in the thrombolytic trials with MR-based imaging serving as the witness for when stroke began. But taking a step backwards, as Josh mentioned, we have also seen numerous advances in advanced imaging techniques. And so much so that the aspect score is currently now kind of outdated, and this is something that really came into play and was at the forefront 4 years ago, 3 years ago. At our program, actually, as stroke attendings, we were required to kind of record an aspect score on all of our stroke patients that came in. but there's just been such evolution in recent times. And for the CT perfusion, just kind of a question for the audience. How many people are at institutions that actually have advanced ischemia view CTP modality? So quite a few, and certainly the bulk of this obviously is probably at advanced primary stroke centers or comprehensive stroke centers. For those who may not be aware, the software is $60,000 from what I'm told to cover for 2 units. And here's a sample case that we had from Yale last month. Of note, the way, for those who don't have the software, the way this works is, at least at our program, is that whenever a patient has the ischemia view CTP performed, everybody who's kind of on the network, so all people who take stroke call, get an immediate feed through email of the images on our iPhone. So I can tell you that we had 2 overnight that kind of came in that were staffed by the stroke team. So this is a patient who actually qualifies for both the Diffuse trial and the Dawn trial, and just kind of going through, if you had to pick the one view to look at that's of the highest yield and highest interest to EM providers, it's this view, which gives you the qualitative information of the core size, indicated in pink, and then the area of oligemia in green. And then down below we have the quantitative information. The core estimate is 14 cc's in this patient, so certainly in the oldest Dawn trial group, the core is less than 21 in this patient. And we have an area of oligemia of 132 cc's with a mismatch volume of 9.4, which is above the 1.8 threshold, and a mismatch total volume of 118 cc's. Now, I'm not a neuroradiologist, but so this is far from being my area of expertise, but there are a number of other images that we do get when our emails receive an email from Ischemia View. And they kind of serve as a double check just to see what the quality of the CTP is. And one such view is this image, which tells you kind of what the volume is of blood that's arriving in the area of the stroke beyond 10 seconds. And so if you see a very large volume beyond 10 seconds, then that supports that the patient is not a candidate and that the collateral flow is just very slow. Whereas in this patient, if you see larger volumes in the quicker area, greater than 4 seconds, greater than 6 seconds, that's a reassuring sign. Another image sequence that we get for the CTP is where the arterial inflow and venous outflow locations are sampled from. And perhaps it may be a little challenging to see on the slide, but you can see a red dot where the sampling is from the M1 portion, kind of right at the T of the internal carotid, and the MCA M1 portion. And then we have a blue dot sampling the venous outflow. And essentially what is generated from this is kind of a peak velocity, peak flow velocity of the arterial inflow and the venous outflow. And qualitatively, you just want to make sure that your curves kind of look like this with 2 spikes to ensure that it's adequate quality. Talking about MRI and then going on to the MR witness trial, which is, as Latha stated, kind of old news already because it came out last month. Interestingly, what was looked at this, and we've kind of known this concept for a longer time period, but really the sequences that they're looking at in MRI is what's called a diffusion FLAIR mismatch. And just for background information, for those who may not be aware, when an ischemic stroke occurs, instantaneously, within the first 5 minutes, you see a restriction of diffusion, as evidenced. Is there a pointer here? Because I guess my pointer on the slide's not working.
You can try to use the mouse as well, if that's not.
Yeah.
Oh, actually, the pointer here. Let me just switch on.
Oh, great.
Use the mouse, but drag it over to the other screen instead of, because you're on the split
Is the mouse visible? No. Okay. Oh, thanks. So here's the restriction of diffusion that you can see in the diffusion weighted images. And on the other panel, we have the FLAIR sequences. FLAIR for background, signal abnormalities take roughly 4.5 hours to present on FLAIR. And so thus, seeing the mismatch can utilize MRI to serve as the witness for when a stroke started. And there's some sites that utilize this in a qualitative way, just an eyeball estimate of a mismatch. For the MR witness study, actually going back to what the work of Ono Wu in 2011, they actually established a quantitative mechanism for doing this, looking at a signal intensity ratio, where they kind of measure the units in each and get a quantitative estimate of what the mismatch is, as opposed to qualitative. And so, moving and talking about the study that came out at the end of April, the MR witness trial results. This was kind of an open label, phase 2, single-armed, multi-centered safety study of IV-TPA in MRI selected patients who met ECAS-3 criteria, so they excluded older patients, they excluded patients with stroke scale scores above 25, and patients who presented outside of the traditional guidelines established IV-TPA window. So they presented within a 4.5 hour and 24-hour window since last being seen well. And they had a diffusion FLAIR mismatch and a signal gradient ratio less than 1.15. The primary outcome of interest was looking at symptomatic intracranial hemorrhage, so safety variable, and determining that the rates would be no different than the ECAS-3 criteria, as evidenced by any ICH and an increase in the stroke scale score of 4. And secondary outcomes were looking at the Rankin scores in each group and rates of asymptomatic hemorrhage as well as cerebral edema. So they enrolled 80 subjects from 2011 to 2015. 71% presented as wake-up strokes. Others presented at other times. The median stroke scale score was 7.5. The median FLAIR signal ratio abnormality was 1.08. And then for stroke subtypes of interest to this group, only 70 patients were able to get large vessel imaging early. And of those 70 patients, roughly 23% had a large vessel occlusion. So the IV TPA treatment was initiated at 11.3 hours from last seen normal, and was given 3.85 hours after symptom discovery. The median door to needle was 1.78, so having protocols that went directly to MRI added a little bit of time. Interestingly, I mean, because this is an issue that's talked about in the emergency medicine literature, the mimic rate was only 1.25, so 1 out of 80 patients were determined to be a mimic. The symptomatic hemorrhage rate for their primary outcome was 1.25% as well. Only 1 patient had it. No different from the ECAS-3 results, which had a 5.3% symptomatic hemorrhage rate. And in looking at their comparison, 5.3%, like I said, was the ECAS-3 symptomatic hemorrhage rate in ECAS-3, so there was no difference. For secondary outcomes, the asymptomatic hemorrhage rate within 24 hours, and this is something, I mean, just for background in the world of emergency medicine, this is something that we see, and we do see it, you know, in the teen range for the most part, or a little bit higher, but it occurred in 26% of patients. This can very often be the natural history of a stroke, to develop a little hemorrhage later on within the 72-hour period. This was no different from ECAS-3 as well, and was not significant. Going to the Grata bars of their total population, all 80 patients, roughly 39% ended up with a 90-day Rankin score of 0 to 1. And of those patients who had were kind of highly functioning before presentation, 43.5% had a Rankin score of 0 or 1. How did IVTPA in this window doing the LVOs. Like I said, only 70 of the 80 patients received vessel imaging, with 23% having large vessel occlusions. There was recanalization with IVTPA in 19% of the LVO patients in this study, kind of consistent with older IVTPA data saying that it works for LVOs, roughly one in 5 patients. So the end conclusions that Lee Schwam and the others drew is that IVTPA is safe and feasible in the context of an extended time window, using MRI diffusion FLAIR mismatch as a surrogate marker for serving as the witness to when a stroke occurred. The response rates appear similar in other studies treating patients within the 3 to 4.5 hour time window since last being normal. The symptomatic hemorrhage rate was only 1.25%, and asymptomatic hemorrhage was detected frequently but not significantly associated with outcome. And with that, we will turn it over to Dr. Ganti.
Okay, so you can see here that we're talking a lot more about treating strokes within the first 24 hours, right? We always used to say TPA within 3 hours, then it went out to 4.5 hours, and now we're talking about 24 hours. And why is that? It's because of all the patients who have strokes, such a minority of patients are actually eligible for TPA with the strict time-based definition of who's eligible. Then what happens is the patients who are eligible, there are a number of factors that prevent them from coming in. Either they don't know about it, they don't want to go to the hospital alone. There have been numerous published papers that say why patients don't come to the emergency department even though they know they're having stroke symptoms. And then in some places when they do come to the emergency department, there are delays in the emergency department and then they don't get their TPA, for example. So with all that, there's really been a renewed focus or a focus on trying to change the eligibility criteria from a time-based symptom or time-based criteria to an imaging-based criteria. So wake-up strokes are strokes that are basically noticed upon awakening. 1 in 4 of all strokes are wake-up strokes. Current practice precludes them from IVTPA because time of onset. There have been some studies that have estimated how many people would actually be eligible if the time criteria was not an issue. And it says that approximately 39% of wake-up strokes would actually qualify for TPA if that was not a criteria. So, okay, I think we talked about that. Very briefly, pathophysiology of wake-up strokes. It looks like, even though patients were last seen normal the night before, when they went to bed, whatever, it looks like pathophysiology-wise, very likely the stroke is happening right before awakening. Hence the eligibility of these patients to be able to have intervention. The circadian pattern is actually similar to MI and sudden cardiac death. So what actually happens in the body early in the morning? And it's funny because I know we're emergency medicine providers, and probably early morning is really in the eye of the experiencer, right? Anyhow, but if you had a regular day shift schedule, the REM sleep is associated with a 30% increase in sympathetic activity. So right before you wake up, you have all the sympathetic activity, and that is probably what has to do with our early morning MIs, early morning strokes, etc. We do know, for example, like atrial fibrillation peaks around 12 a.m. or midnight. I'll remember that next time I'm on a night shift. But we know that when you convert from AFib to sinus, that itself is an independent risk factor for stroke. So wake-up stroke versus known onset of TPA. It's so funny because we made all these slides ahead of time, and then when we were making them, we thought, okay, well, this is what we're going to do. And then even as SAEM is coming up days before, we had to keep changing them and updating them because more and more published work has been coming through. So wake-up stroke, bottom line, is it seems to actually occur very near to waking up, not very near to when you last went to bed. And we have several published trials now. So this trial that I'm going to talk about, MRI-guided thrombolysis for stroke with unknown time of onset, actually was published about 72 hours ago. So this was an investigator-initiated, multicenter, randomized, double-blind, placebo-controlled clinical trial, and they enrolled subjects who had unknown time of onset for their stroke. But they had to meet MR imaging criteria. And the criteria were, I'm actually go over the criteria in the next slide, but they had to otherwise meet eligibility for intravenous thrombolysis. The primary endpoint was a favorable outcome of Rankin score 0 or 1 at 90 days, which we've seen in all the other trials that have been presented so far. And the secondary endpoint was the likelihood that alteplase would lead to lower ordinal scores on the modified Rankin scale than would placebo. Their imaging criteria on MRI, again, just like Mr. Witness, was a mismatch between the DWI and FLAIR imaging. So you have to have a lesion on the DWI, but no corresponding lesion on the FLAIR imaging. Together, this finding is considered to represent the MRI signature or witness, as we heard before, of an ischemic lesion that is no older than 4.5 hours, because it takes approximately 4.5 hours for you to see the lesion on FLAIR. So if you look at this picture here, so the panel A, you'll see that there is a lesion on the DWI, but not on the FLAIR. Right there, you see the lesion on DWI, but not on the FLAIR. And similar on panel B. When you look at the bottom panels, panel C and D, you'll see the lesion on both the DWI and FLAIR imaging. So if the patient shows up, you do the MRI, and you see that they have imaging that looks like panel C or panel D, then they would actually not be eligible because, based on MR criteria, their stroke is probably older than 4.5 hours. So they screened 1,362 patients and enrolled 503, and this trial went from 2012 to 2017. Interestingly, it was stopped early due to lack of funding. I don't know, I thought that was a little curious, but anyhow, their target was 800, and they were able to enroll 500. 254 were assigned to alteplase, 249 to placebo, so roughly equal numbers. The baseline characteristics were all similar, except there was a higher rate of intracranial occlusion of the ICA in the alteplase group. Approximately 35% of the patients were female, with the mean age of 65 plus or minus 11 years in both groups, and the median NIHSS was 6 in both groups, with an interquartile range of 4 to 9. So the median time between symptom recognition and TPA administration was 3.1 versus 3.2, again very similar. The median interval between the time that the patient was last known well and treatment was given was approximately 10.3 and 10.4 hours, similar to the 10.1 that we heard in prior trials. So in terms of outcomes, the patients who received alteplase, 53% had a good outcome versus 42% in the placebo group. So a statistically significant difference in patients who received treatment versus those who did not. The symptomatic hemorrhage rate in the alteplase group was 2% versus 0.4% in placebo. And then on the bottom figure there, you see that the reason for the unknown time of onset, majority, like 89%, was due to nighttime sleep or wake-up stroke. There are some articles that look at the differences between patients who have wake-up stroke versus just random unknown time, daytime sleep. I feel like that applies to me probably, but those were fewer patients in this trial. This table just kind of summarizes the efficacy standpoints, both primary and secondary, and what you see is that if you look at the top line over there, in the alteplase group, the odds ratio for favorable effect was 1.61, and so they had a favorable outcome at 90 days as defined by the Rankin score. The secondary efficacy endpoints included median score on a modified Rankin, the correlation between treatment response at 90 days and deficit level at basetime, and you can see that all of these favor the treatment group. You're probably used to seeing these kind of graphs by now, or these kind of pictures. And what this shows us is that in the treatment group or alteplase group, these scores are shifted towards the 0 and 1 side, or favorable side. So you'll see there's a significant difference favoring the alteplase group over the placebo group in the overall distribution of scores. So in conclusion, among patients with acute ischemic stroke and an unknown time of onset, if you have an MRI that shows you there's a lesion on the DWI but no lesion on the FLAIR, then having these patients receive intravenous thrombolysis resulted in a better functional outcome than treatment with placebo. All right, now we're going to move on to another agent. So far, I've been talking about alteplase, and everything we've said has talked about alteplase. We now actually have 2 trials that have looked at a different agent. And this is pretty exciting because I think in all the years of stroke research, we've only talked about one agent. So this trial, tenecteplase versus alteplase before thrombectomy for ischemic stroke, also known as Extend-IA, looked at TNK, tenecteplase, versus alteplase prior to thrombectomy in patients with a large vessel occlusion. So they needed to have either an internal carotid artery occlusion, basilar, or MCA. And actually, the trial set out to prove it was non-inferior. That's all they were going to do. They were going to say, you know what, you can give tenecteplase, and it's as good as alteplase. That was their goal. And actually, they found in the results that not only did it meet non-inferiority, but it actually demonstrated superiority. So that was pretty exciting. The outcome was reperfusion of greater than 50% on the initial angiogram. And they had a total of 202 patients across 13 centers in Australia. And because right now, tenecteplase is, you can correct me if I'm wrong, but still not approved in the United States for stroke, right? So only approved for MI. In the TNK group, 22% better outcome compared to 10% good outcome in the alteplase group. 90-day outcome better with tenecteplase. The median MRS was 2 rather than 3. And that's actually a big deal because at 3, you are no longer able to be independent. So yes, 3 is better than 4 or 5, but the cutoff between being able to live independently and not is between 2 and 3. So at 2, I'm still able to live on my own. At 3, I'm going to need some help. Tenecteplase is actually, I should have said this before, but is a genetically modified TPA that has enhanced fibrin specificity and a relatively long half-life. This long half-life is what allows it to be delivered as a single bolus administration. So when we give alteplase, currently we have to give a bolus, and then we have to give the rest of it over an hour. And with tenecteplase, you can just give it as a single dose bolus, so that has a lot of advantages. The dose is 0.25 mg per kg, single bolus, and it's approximately $3,000 cheaper than alteplase. So definitely got a lot of promise there. I wanted to note that the median NIHSS in this study was 17, and the reason I say that is because in the next study, NORTEST, which is published just in August 2017, this was a phase 3 randomized open-label blinded endpoint trial that looked at whether patients could get tenecteplase and what were the outcomes there. So they enrolled patients who had ischemic stroke symptoms and eligible for thrombolysis within the 4.5-hour window. There were 1,100 patients that were randomized either to tenecteplase or alteplase, and the median NIHSS is 4. So I make the point here because in the prior study that I talked about, the Extend IA, the NIHSS was 17, whereas here it was 4. So this is a much milder group of patients, milder stroke. By 3 months, 5% of patients had died in tenecteplase group compared with 5 in the alteplase group, so no real differences there. But what they found was that the primary outcome was achieved by 64% in tenecteplase group and 63% in alteplase group. So this study that focused on the mostly milder strokes found that tenecteplase was not superior, that it was, okay, maybe non-inferior, but not superior like Extend IA did. But I just wanted to point out that there's difference in stroke severity across the two studies. So in summary, because we wanted to leave enough time for a panel discussion and questions, because I know this is an area that a lot of people have lots of commentary on. In summary, we wanted to highlight the studies that are new and provide us with a new time window. So from before to now, we have a new time window that is imaging-based treatment out to 24 hours and includes the population of patients who have wake-up strokes. We now have a new agent, tenecteplase. We now have new imaging modalities, MRI, CTP, CTA. So new opportunities and challenges for EMS. I guess one thing that we didn't talk about is pre-hospital. There was a large systematic review that just looked at which scale is best for pre-hospital personnel to use to, for example, to predict LVO. Because if you predict LVO, the question is, should you take that patient directly to a comprehensive stroke center and bypass? So there was a large systematic review that was just done, I don't know, in the last month or so, right? January. And they found that there was no particular stroke that offered any advantage. So that's that. So that's the latest and greatest on pre-hospital stroke scale assessment. But new opportunities and challenges for EMS nonetheless. And the new guidelines, everybody knows the new guidelines came out in January 2018, and about a month and a half later, several of those guidelines were rescinded. Very interesting. And so finally, new role for emergency medicine. Just all this new, latest and greatest stuff in stroke. With that, I'm going to open it up for panel discussion. We have many of our neurointerest group members here, and anyone in the audience who would like to ask something, please do so. Thank you.
Thank you. So maybe we'll start with opening with questions, and if people don't have questions, we certainly have some of these questions that we're just going to open for discussion amongst ourselves, and we'd love to have the audience weigh in as well. And please use the microphone because it's easier for them to record it.
When is the determination made that the TPA is not working and you're going to do rescue IR? You know, what's the time cutoff?
Sure. Do you want to weigh in on that? When do you? So the question is, when you do you give IV TPA, wait some period of time to see if it worked before then deciding on thrombectomy? Is that the question? And if so, what's that period of time?
Yeah, that's a great question. In terms of what we used to do in our institution, we used to extrapolate from the cardiac literature and wait 30 minutes. That was in the time period that we had one interventionalist and two interventionalists. But now, in all honesty, I mean, it takes us probably 75 minutes to get our cath lab all ready. So, I mean, if there's an LVO and we're giving TPA, we will now, in our system, activate a Tier 2 cath lab activation. And if the patient does get better, we will, you know, just abort the procedure. But we want to get everything in line so that we can go to the cath lab as quickly as possible because, you know, like we kind of talked about, you know, the older TPA literature demonstrates that it works probably 1 out of 5 times for LVOs. You see the TPA versus TNK, extend IA results, and then you see the MR witness results as well for thrombolytic, IV thrombolytic efficacy for large vessel occlusions. So that's the decision that we've made in our system to kind of just activate, but then opt out if the patient does get better.
Yeah, and I'll add to that. I think that for a lot of interventionalists, the benefit of endovascular therapy seems so large now with all these recent trials that most people are pretty hesitant to say, oh, there is a large vessel occlusion, it's causing you a stroke, but we're going to include some period of waiting time in there. And I think most people are not interested in that and just moving forward with the process, especially because the benefit of endovascular therapy is large and time dependent. So losing that time is probably working against you. Next. Yep, and you got another one? Him first, and then we'll come back to you. How's that?
So we're wrestling with this right now, and I guess the question that I have, I think it was the 2016 guidelines and then the 2018 guidelines, and basically I didn't see a lot of new literature come out other than they looked through registries, and I think the group kind of changed their mind on the 3 to 4.5 hour window. And maybe I missed something. That's why I'm asking the question. Maybe I missed something there. But and then their wording, very specific, having written guidelines. You know, they hedged everything except for the high NIH score. The high NIH score, they basically gave it basically a neutral recommendation. So the guidelines that we're writing, basically everything in the 4.5 window, we have left everything out for exclusion except for the high NIH of 24 because it seems to be fairly nebulous in there. So educate me. Did I miss something between 2016 and 2018 that was rocking that said that 3 to 4.5 hour window, now all those exclusions go away?
No, I think what they've really done is gone from absolute exclusions to relative exclusions because they were initially developed by looking at the SITS databases to see which people did not respond in that later time window. And then that was used in the design for ECAS-3. And then ECAS-3 was the basis of the later IVTPA time window. And over time, what we found is that that 80 years of age is kind of a different physiologic status for different people. So you have great 80-year-olds and you have really, you know, sick 80-year-olds. So that became a relative exclusion criteria. In terms of having a stroke scale greater than 25, that's a huge clot burden usually, and for IVTPA, that's not going to be a feasible thing. So that when you look at, in the original studies, stroke scales greater than 20 that had large clot burdens, you only had about a 10% rate of patients that responded to TPA in that group. But those also kind of portend severe early ischemia. And so when you look at the stroke scales at 25, you often have early ischemic changes, so it's relatively futile to treat those patients, or it'll increase your hemorrhage rate. So those people have a really poor outcome anyway you slice it.
So the small amount of edema is not going to, it's got to be greater than 1/3 of the territory. So if it's small, I don't know if that's going to make a lot of difference. But
Right, small amount of edema doesn't, and there are papers that looked at that, and the NIH stroke scale was actually a better predictor of outcome than the amount of edema and the 1/3 MCA rule.
Right. So I guess the question I have for you, Chris, since you're right down the street from me, have you rewritten your stroke protocols, and if you could, share them with, because basically,
Sure.
now I've moved everything from the 3-hour window to 4.5-hour window, except for I have not included, I have continued to have the exclusion of NIH greater than 25. Is that fair?
Yeah, I think that's fair.
And the age of 80 for that ECAS 3 to 4.5 hour time window.
Yeah.
And that's for the, that's obviously for the intravenous thrombolytic literature. For the thrombectomy data, I mean, certainly, on a clinical basis, I mean, we include and consider a lot of these patients that may not meet ECAS 3 criteria. They may go to our cath lab without receiving IV TPA if they were presented 4.5 hours. They're 95 years old and have a M1 occlusion, but that does not preclude us from going to thrombectomy if it's a highly functioning patient.
So for that extended window, just to make sure I got this right, because I think other people are going to end up copying this. So NIH greater than 6, less than 8, CTA, CTP, consult neurointervention, NIH greater than 10, between the 8 and 24-hour window, same thing, CTA, CTP, consult neurointerventional. Yes?
For the most part, yes. Yep.
What did I miss?
Well, that is correct. I mean, there is physician discretion that kind of goes into it, and our response is that we have a stroke attendant responds and a stroke attendant is at the bedside for all revasc cases within 30 minutes, looking at imaging first from home and kind of working with the EM team immediately. And there are some times when we consider other exclusion criteria that aren't traditional. So active vasculitis is something for IV TPA that we may exclude on.
Good.
And then there's other patients that we may take, so to speak, off label and just trying to in a Hail Mary sense, trying to heroically improve their symptoms because they were highly functioning.
Great.
I'll add one thing, because the thing in my mind that really threw me off about the wake-up stroke trial is you talk about these folks who are presenting like after 6 or 8 hours and putting them on the train to the endovascular team. But if the reason for that they're 8 hours or 10 hours is that they're a wake-up stroke, do we now have to reorient our thinking and so crap, maybe actually they should go to MRI and think about IV TPA, And I don't know what your rapid MRI availability is. We have an MRI in our ED, and it's still a pain in the ass, frankly, to get quickly, and it's staffed 24/7. So we can do it, but it's a big production. But now I'm like, oh crap, do we need to really start like pushing that to move along quickly? And is the wake-up stroke, is it there's something physiologically about wake-up, or is it really that it's just telling us that MRI is just better than the timing is? Even if the patient can tell me their time, the MRI is still better at giving me sort of a opportunity to benefit from therapy.
And I'll throw out another systems curveball to think about now with all the literature too. You're going to find your MRIs and thrombectomy teams at comprehensive stroke centers. So I mean, if you have a patient who's presenting in that 4.5 to 24-hour window, should EMS go directly to a CSE because that's where MR capability is and that's where your thrombectomy team is. It's another systems consideration that acute stroke ready centers or some primary stroke centers may not have access to.
Well, that's an interesting push, because right now we have all that except for MRI is still very difficult to get. Maybe they'll have to take them all to Forge. How quickly can you get an MRI?
Oh, we can easily get an MRI within a day or two.
Our MRI is probably, in all honesty, a quarter mile away, but we have a hyperacute process that gets them on the table. They pull a patient off the table in the magnet. We have an ED nurse, ED tech, and the neurology resident. They just basically run a quarter-mile sprint to MR to get the image. And if it's a TPA-eligible patient, they will bring TPA and push it in the MR post-image area.
Rob? It's great to be in the era of stroke where we can say, hold on, I'm not sure we know as much, and I'm not sure this is as great as we think it is, because we had so many years where it was, this isn't as bad as we think it is, But we're saying some things that I'm not sure we've really done, right? So none of these trials, we talk about them as if we have tested and proven something about imaging selection. But none of these have tested imaging selection, right? What they've tested is an intervention in a patient population that was selected. But that's different than testing the selection. We don't know what the endovascular devices would have done in a non-imaging selected patient population.
That's
and
true.
It could be that what we've had is an evolution in the endovascular devices that makes a big difference, right? Because we did have previous trials that did look at that. We did MR selection based on diffusion-perfusion mismatch for MR rescue and with the old Mercy endovascular devices, and it didn't work, right? So we changed our devices, selected with a slightly alternate way of looking at diffusion-perfusion mismatch, and it worked unbelievably well, right? So we still haven't tested the selection method. And with the wake-up stroke, now we're looking at an MR selection that is a different mismatch, right? I mean, it's a mismatch trying to get at a correlate of time. I mean, if that's true, then it's still probably better to use the diffusion-perfusion mismatch than what was looked at in those studies, which was the FLAIR diffusion mismatch, right? But, who knows, because we didn't compare them. And they were in the MRI scanner. We could have, right? I mean, where's the comparison between, but again, because they didn't treat everybody, what they should have done is MR'd everybody. They should have done the MR rescue methodology, right? You take everybody, you do the MRs, you could do perfusion-diffusion mismatch in MR, you could do FLAIR DWI mismatch, give everybody, randomize everybody to TPA versus not TPA, and then you would be able to say, in an unselected patient population, how well did TPA do in wake-up strokes? In people selected by FLAIR diffusion mismatch, how well did people do? And in perfusion diffusion mismatch, how well did people do? I mean, that would have been the scientific way of doing it. People don't want to do that because they're afraid that the TPA would have been devastating in an unselected wake-up stroke population. But we don't really have prior evidence that that's true. So one of the things I guess we don't know, and I want to make sure we don't know, and I guess the question is, what do you think?
Yeah.
But we need to test these selection criteria. We need studies that actually compare the selection criteria, because even if you buy the fact that, I mean, I do buy the fact that imaging selection probably works, but the imaging selection criteria used in Dawn and Diffuse can't be the right imaging selection criteria, right? Because people did so unbelievably well that if those are true, then people who don't quite meet that have got to do well too, right? Maybe not as well in those studies, but it can't be that they just happened upon the exactly right thresholds, especially if those results are right. So I think what we've learned is what we've definitely learned, and that's most exciting, is that there are patient populations out there that can get reperfused after 3 hours and do really well, right? That's what we know. We don't know who they are. And doesn't the next round of studies really need to be to test these different selection criteria against each other and find what the thresholds are?
So I would say a couple things. So one is, we do, as you said, we do now have a couple groups that if you take this group in this circumstance, treat them, the endovascular therapy provides benefit. But as you said, I don't know, is it that the device is better, or, and it's not really that we have a clever imaging tool, it's just that we did we got a better cohort. So I think the real question is, can you now that you have a cohort that will benefit, can you now expand that, now enroll people who wouldn't meet that criteria? Is that what you're saying? Or are you saying?
Yeah, you have to.
Right. Which is different than saying, now let's go redo MR rescue, for example, and take some people who we would treat with these trials and now randomize them to placebo in the name of selecting better imaging. That's not what you're saying, right?
Well, so it's harder to do the MR rescue now.
It's now hard to do it. You wish you could go back in time and do MR, right, and do like all the imaging tools, but randomize all the people.
But you can still do MR rescue minus that quarter, right?
Right.
Minus that quadrant, right?
Yes.
So that quadrant
minus the people from this trial, right?
Right.
Yes. I think you could do that probably. Like it expands. Can we now expand the people who will benefit with? Now that we're doing X, can we make a larger cohort that we do X with?
Yeah, and I guess, can we not go around telling people that we've tested the diffusion-perfusion mismatch hypothesis and proven that it's true? Because
No, that I don't think
we don't know that.
we don't know that, but I don't think that's how the message is going to come out. And I think that it's unlikely that these imaging modalities will really be tested against each other and you find that threshold. But I do think that there's going to be mission creep, so that when you do, when you look at the enrollment criteria over time, those actually start to loosen up a bit. So I don't know, maybe the answer would be in having registries, so that you could actually figure out from the registries where your things are. I'm not sure if that would give you the data that you need or not, but I feel that the things that MRSQ kind of suffered from and IMS3 suffered from was that once the Mercy retrievers came out, they're used clinically so much that it was hard to enroll patients into there. And so we have learned from those studies, but I think now that you have the retrievers, I don't think going back to figuring out exactly which patients to use them on based on imaging is actually going to happen. I think the horse is out of the barn. I don't know if you guys feel that way or not, but I think that people are running
I think
with
mission
this.
creep is a huge problem. I agree. In fact, that was one of the strengths of Mr. Clean, right? Was the Netherlands said we'll only pay for it if you do it under if you put people in the trial. And so the question is, could the U.S. ever move to that world, or do you have to do these trials in the Netherlands where they could say we won't pay for it if you don't, we won't pay for it unless you outside of the quadrant that we know benefit, we won't pay for the other ones. We won't pay for mission creep. So I think if we could find either environments like that or make our environment like that, we could then do those studies.
Nina.
Question, kind of changing tack quite a bit. To the last point that was on the last slide, that was left with a question, and that is, what is the role of emergency medicine? Not to be too philosophical about it, but there's lots of us are involved very intimately in stroke care, and an awful lot of people in emergency medicine have a very limited role in stroke care. And I think, in many ways we end up talking to sort of the people that are much more involved, and don't really know what we can do to translate a lot of the details to the people that are, to the masses. And I guess my question, it's as much of a statement as that I think we should, but I think maybe it would be helpful to know, like, what are some individuals' roles as emergency physicians in your stroke systems, right? What do you all do? What do you do as individuals? How are you involved in terms of not only your own department, your health systems? How do you get involved, or how are you involved? And maybe that can help to stimulate the rest of us.
Nina, I think it's a great statement and question. I think as a community in emergency medicine, this falls on us, right? This is very challenging for us as a community because there's been so many changes over such a short period of time. So it's very challenging for for any emergency provider to know what to do in many of these situations. So I think it falls on us as a broader community to make sure we're educating our colleagues that see these patients from time to time, and very infrequently, right? So. In terms of involvement, I think most major medical centers are going to have either primary or comprehensive stroke center certifications, and getting involved as much as possible is going to be important. We have as emergency medicine at the university, we have it's co-chaired by emergency medicine and neurology, and so emergency medicine, because we see the patients, it becomes important for us to take leadership roles within these broader communities. But I think your statement is very well founded that we need to make sure that we're educating ourselves as emergency physicians, because most places aren't going to have a neurologist that comes down to the ED to see these patients and make decisions on their behalf.
Oh, I guess I was going to make a small comment, which is just that one of the things we've talked about in the neuro interest group is to put out sort of summary things that would be useful to community emergency medicine physicians or, community physicians who are maybe not in the neuro interest group, just to kind of summarize, like, what is their role, and to provide, nuggets of information that would be practice applicable.
All right, and I think to be respectful of people's time, I think we're going to wrap, unless you want one last question.
A quick one, relatively
Sure.
quick one that really is a question. So we were talking yesterday about whether we're ready at our institution to switch from TPA to TNK. And I think, you left out the older evidence from Australia and from the NINDS trial that was published in 2010. And I think it all speaks to non-inferiority. So are you ready to switch tomorrow, today?
We're ready to discuss it. We're not ready to switch today.
Right, we're in the same boat. I would be in favor of switching, but that would need to go through an institutional process.
I think it's going to come, and there's 2 centers in Australia, as I mentioned in the interest groups meeting yesterday, that are already doing it, and this was a conversation that I've talked about with people on the Stroke Association, Stroke Council, and it'll be interesting to see how things evolve. It certainly is going to, IV push versus infusion is going to be easier for freestanding emergency department satellites that don't have to send a nurse on the ambulance because TNK is a bolus. So from a systems perspective, it certainly is going to be a lot easier. And, it certainly seems like there is demonstrated equivalence in the NORTEST trial and the Extend IA. Maybe, and I defer to people who are smarter than me in the room, maybe StrokeNet will have to do the pivotal final comparison for this before change is really promulgated nationally and by different guidelines, but I predict it will be a part of the future.
No, I agree. I mean, my feelings on it, Robert. I think we're going to investigate it as an institution. I think we should do that sooner as opposed to later. We do things off-label, and I think this has such promise that I think it's worthwhile to have that discussion and to start going forward.
All right, we're going to wrap up. Thank you guys very much.